Hello, and thank you for joining this OncLive TV Peer Exchange. This program will feature a distinguished panel of experts, each well-known in our professional community, who, with me, will exchange insights into the challenges of treating metastatic breast cancer and locally advanced breast cancer in community-based clinics. Our panelists will comment on recent clinical trial evidence, discuss how it might inform treatment decisions in mid-2014, and remark on the remaining challenges in a form of cancer that affects so many individuals. I'm Dr. Adam Brufsky, Professor of Medicine at the University of Pittsburgh, Associate Division Chief of Hematology Oncology, and Co-Director of our Comprehensive Breast Cancer Center. Joining me today are Sarah Hurvitz, who is Associate Professor of Medicine at UCLA, Ronald Reagan Medical Center in Los Angeles, Terry Mamounis, Professor of Surgery at University of Florida Health Center, Orlando Health, Hope Rugo, Professor of Medicine and Director of Breast Oncology Clinical Trials Education at the University of California, San Francisco, Helen Diller Family Comprehensive Cancer Center in San Francisco, and Dia Vodoris, Clinical Associate Professor of Medicine, Manhattan Cancer Specialist, Mount Sinai School of Medicine and Lenox Hill Hospital in New York. Thank you to each of you for joining us today. Let's get started. So let's begin our discussion by gathering your general thoughts on the role of chemotherapy and other systemic therapies in metastatic breast cancer. And Dr. Vodoris, generally when a woman presents to you with metastatic disease, what makes you think of kind of how you want to treat her? In other words, whether you want to give her chemotherapy or just hormonal therapy.
Yeah. That's actually a very good one. When a woman presents, it's not one size fits all. We, of course, the first thing we look at is when she's metastatic, the sites of metastases, the biomarkers, whether she's HER2 positive or negative, hormone receptor positive or negative, her age, her performance status, any prior therapies she's had, and really what in conjunction with the patient, we have a discussion about the types of treatments and the types of toxicities, and regarding the evidence of progression-free survival and overall survival.
Okay, and I guess let's confine it just for the time being, say to triple-negative breast cancer. So let's just say a woman comes into your clinic. She maybe had 2 or 3 lymph nodes positive, say 3 or 4 years ago. She had triple-negative disease. You gave her whatever your standard adjuvant therapy of choice was, and we can talk about that at length if we so desire, and we can. And now it's 3 or 4 years later, and she comes to you now with several liver metastases. She's asymptomatic. What kind of things would you think about giving her at that point?
Yeah, so we always want to use our main players are the anthracyclines and the taxanes. We want to use those. If we haven't used them, we would consider using either an anthracycline or a taxane. If the patient has been exposed to either in the adjuvant setting to anthracyclines and taxanes, I would consider either capecitabine or another taxane, depending on whether or not the patient is willing to undergo oral chemotherapy versus IV chemotherapy, and based on the side effect profile, we decide whether or not we'll do that.
Okay, so we've been through a lot of different systemic therapies, trying to figure out what to use in metastatic breast cancer, and in particular which kind of taxanes to use. And I know there was a large clinical trial that Hope ran. I think it's been published now, hasn't it, at this point, or not?
Not quite yet.
Oh, it hasn't been published. Oh, I thought it was published already. But comparing the taxanes. Hope, can you talk about that CLGB study?
So the CLGB study 40502 randomized women who had metastatic breast cancer, HER2 normal, who hadn't received any chemotherapy for advanced disease, to receive weekly paclitaxel, 3 on, 1 off in our standard schedule, or weekly ixabepilone, the apothelone, or weekly nab-paclitaxel, all using the same schedule. And because at that time, bevacizumab was approved for the treatment of metastatic HER2 normal breast cancer in combination with taxanes, all patients received bevacizumab. After ODAC recommended that the approval of bevacizumab be withdrawn, we made it an optional requirement, an optional use, but everybody gave it anyway. So that trial actually is very interesting. It was an adaptive randomization so that we could look at the results as we went along in our pre-specified interim analyses and reduce the number of patients if it was likely that we weren't going to reach an endpoint. The endpoints were comparing either IXA to the paclitaxel or nab-paclitaxel to paclitaxel, so not the two experimental agents to themselves. What we found actually was an earlier interim analysis that ixabepilone was not going to be superior and actually looked inferior with that weekly schedule. And then at the final analysis, which actually was still an interim but ended up closing the trial, we found out that nab-paclitaxel was not going to be superior to paclitaxel. And in the final analysis, it was actually quite interesting that the ixabepilone dose was probably too low because it wasn't as good as paclitaxel, and the toxicity was less than we're used to seeing. But you can't increase the dose of ixabepilone because you get too much toxicity, so you're between a rock and a hard place. In contrast, nab-paclitaxel was used at 150 milligrams per meter squared because there was a lot of interest based on a Russian randomized phase 2 trial on the part of the makers of the drug to really test that higher dose to see if it could overcome resistance. But what we found was that it was too toxic. So that dose caused unacceptable rates of hematologic and neurologic toxicity, specifically peripheral neuropathy. So what happened was people started and they immediately dose reduced or came off drug. So you didn't get enough drug in there. So what we ended up seeing was even with those dose reductions, relative equivalency of nab-paclitaxel to paclitaxel and inferiority with the ixabepilone.